We are in the last part of our video. We have successfully completed part 1 and 2. In this part, I am gonna conclude this video. So let's get into it. In the last part, I forgot to include kidney. So we'll start with it. Kidney. On a physical examination, a kidney is characterized by a palpable upper border. One can feel space between the kidney and the costal margin. It moves inferiorly on inspiration. It is palatable. The percussion note is usually resonant because of overlying loops of gas-filled bowel. And now we'll go through musculoskeletal system. The primary method used for physical examination of musculoskeletal system are inspection and palpation. Percussion and occultation are only used in special situations, such as percussion pain of vertebrae, occultation for bone crypsis. General considerations. The musculoskeletal examination is typically tailored to the patient concerned. Procedures include gross inspection, assess mobility, compare affected and unaffected side, perform percussion and palpitation in case of tenderness, assessment of strength. Spine. It is essential to observe the patient's gait and posture. Inconsistency between observed function and performance during specific tests may help to differentiate between physical and functional causes for patients' symptoms. Inspection. Examination of any localized spine disorder requires inspection of the entire spine, and the patient should therefore undress himself. Look for any obvious swellings or surgical scars. Assess for deformalities like scoliosis, loss of lumbar lordosis, hyperlordosis of lumbar spine, and also look for shoulder asymmetry and pelvic tilt. Observe the patient walking to assess for any abnormalities in gait. Palpitation. Palpate for tenderness over bone and soft tissue. Perform an abdominal examination to identify masses and consider a rectal examination. Quadriquina syndrome may present with lower back pain, pain in the legs, loss of anal tone and sensation, and unilateral bilateral lower limb motor and/or sensory abnormalities. And next, shoulder. Shoulder pain is one of the most common complaints in the outpatient setting. In examining a patient with a painful shoulder, we should start with a general inspection like looking for musculoskeletal abnormalities and any associated functional defects. The physical examination of the shoulder starts by observing the patient removing his shirt. This is the first opportunity to notice any functional impairments of the shoulder joint. General inspection. Once the patient has uncovered the upper trunk and extremities, we can move to a general inspection of the front, the side, and the back of each shoulder. Our goal is to identify any abnormalities in the muscle bulk or any asymmetric bony defects. Cervical spine. Before proceeding with the examination of the shoulder, it is very important to complete a full examination of the cervical spine to make sure that no spinal pathologies are contributing to the presentation. Range of motion. We should test the range of motion of the shoulder in different directions, such as flexion, extension, and rotation. If movement in a specific direction is painful or limited, this may signify that pathology is in a specific structure of the shoulder. For all these maneuvers, have the patient standing in front of you. Forward flexion. Starting with the patient having the forearm fully extended at the elbow with the arms attached to the side of the trunk. Ask the patient to flex the arm at the shoulder by moving the upper extremity anteriorly and superiorly until it is above the head. Extension. Starting with the patient having the forearm fully extended at the elbow and the palms supinated, ask the patient to extend both arms at the shoulder by moving the upper extremities posteriorly. Abduction. Ask the patient to abduct both arms by elevating them laterally until they are above the head at 180 degrees. Cross-body adduction. Have the patient flexing the upper extremity forward to 90 degrees. From this position, ask the patient to maximally adduct the shoulder by moving the arm horizontally. all the way to the other side. Make sure to test one side at a time. External rotation. Ask the patient to flex the elbow at 90 degrees with the arm attached to the trunk and the palm supinated. Then have the patient externally rotate the shoulder by bringing the forearms laterally. Internal rotation. First, ask the patient to flex the elbow at approximately 45 degrees with the fist clenched and the thumbs up. Then ask to position both hands behind the back until the thumbs touch the apex of the homolateral shoulder. This maneuver tests for the functional integrity of the internal rotation of the shoulder. Scapular motion. Before completing the inspection of the shoulder, it is good to practice to repeat all the maneuvers that test for the range of motion while observing the movement of the scapulae. Any asymmetries in the rhythm of scapular movement would indicate pathology in the anterior aspect of the shoulder. Elbow. Inspection of skin is main and also observe for any swelling. Patients with elbow effusion will generally hold elbow flexed at 70 to 80 degrees, flexion at rest. Position of maximal elbow, capsular distinction, fullness of the elbow, soft spot and hypertrophy are also seen. Elbow carrying angle in full extension. Normal carrying angle is equivalent to 11 degrees in men and equivalent to 13 degrees in women. This will be higher in sports person. Palpitation, bony prominence, all-carinin, medial epicondyle, lateral epicondyle and radial head are best palpitated while rotating forearm from pronation to supination. Radial tunnel syndrome. Maximal tenderness is 3 to 5 centimeters, distal to lateral epicondyle. Lateral epicondylitis. Point tenderness at ECRB insertion into lateral epicondyle. Few distal to tip of lateral epicondyle. Medial epicondylitis. Tenderness 5 to 10 distal and anterior to medial epicondyle. Soft tissue swelling and warmth if inflammation is present. Range of motion. Check passive and active motion of both sides. Check for creptors and mechanical blocks. Flexion extension normally 0 to 140 degrees. If functional, 30 to 130 degrees. Pronation to supination. Check with shoulders fully adducted and elbow at 90 degrees. Normal pronation is 75 degrees and supination is 85 degrees. If functional, pronation and supination are 50-50 each. Stability, varus and valgus stability. Flex elbow to 20 to 30 degrees externally and rotate the humerus and apply valgus stress. And next, hand and wrist. Perform a brief general inspection of the patient looking for signs suggestive of underlying pathology, scars and wasting muscles. Dorsal aspect of the hand. With the patient palms facing down, inspect the dorsum of each hand for signs suggestive of underlying pathology. Hand posture. Note for any abnormalities. Scars, swellings and skin color also observed. Bouchard's notes occur at the proximal interphalangeal joints and are associated with osteoarthritis. Hibern's notes occur at distal interphalangeal joints and are associated with osteoarthritis. Skin thinning can be associated with long-term steroid use. Palmar aspect of the hands. With patient's palm facing up, check for hand posture, scars, swelling and Dupuytren's contracture. This involves thickening of the palmar fascia, resulting in the development of cords of palmar fascia, which eventually cause contracture, deformalities of the fingers and thumbs. Palpitation with thumbs up. Assess for temperature and compare the temperature of the joints of the hands and elbow using back of your hands. Increase the temperature associated with swelling and tenderness may indicate septic arthritis or inflammation arthritis. Radial and ulnar pulse. Palpitate the radial and ulnar pulse to confirm adequate blood supply to the hand. Palmar thickenings. Support the patient hand and palpitate the palm to detect the typical bands of the thickening palmar fascia associated with Dupuytren's contracture. Median and ulnar nerve sensation. Assess medial nerve sensation over the tenar eminence and index finger. Assess ulnar nerve sensation over the hypotenar eminence and little finger. With palms down, assess radial nerve sensation. It is sensed over the first dorsal web space. Temperature. Assess and compare the temperature of the joints on the dorsal aspect of the hand and elbow using the back of your hands. Metacarpopharyngeal joint squeeze. Gently squeeze across metacarpopharyngeal joint and observe for verbal and non-verbal signs of discomfort. Movement. The joint of the hand and wrist should be assessed and compared. Active movement. It means performed independently by the patient. Ask the patient to carry out a sequence of active movements and note the restrictions. Finger extension. Open your fist and splay your fingers. Finger flexion. Make a fist. Wrist extension 90 degrees. Put the palms of your hands together and extend your wrist fully. Wrist flexion 90 degrees is normal. Put the back of your hands together and flex your wrist fully. Passive movement. This refers to the movement of the patient controlled by the examiner. Ask the patient to fully relax and allow you to move the hands and wrist for you, and warn them that they should experience any pain. If in case of any movement, they should let you know immediately. Next, knee inspection involves skin discoloration, wounds, gross deformity or previous scars, soft tissues, swelling, muscle atrophy, asymmetry. Bone length compared to contralateral side position, varum or valgus flexion contractures, gross deformity or malalignments. Gait varus thrust can indicate injury and painful, that is antalgic, shortened stance phase on affected side. Flexed knee gait from thigh, from thigh Achilles tendon or hamstrings. Palpitation, bone, joint line, tenderness to palpitation medially or laterally. Patella, translation facet, pain to palpitation, soft tissue structures. Patellar tendon, quadricep tendon, collateral ligaments. Swelling, prepatellar bruits, intra-articular effusions, etc. Range of motion flexion 125 to 135 degrees, extension 0 to 10 degrees, hyperextension, rotation 10 to 15 degrees internal and external, stable femur tibial rotation. And lastly, hip. Observe the resting position of the hip. Secondly, hip deformity or swelling, and next overlying skin changes, and also hip asymmetry such as leg length discrepancy and SI joint dysfunction. Also see hip range of motion for normal findings. They are as follows: flexion 120 to 135 degrees, extension 20 to 30 degrees, abduction 40 to 50 degrees, adduction 20 to 30 degrees, internal rotation 30 degrees and external rotation 50 degrees. Perform active range of motion and passive range of motion. Pain on even slight range of motion should suggest intrinsic hip pathology. Mobility and gait. See abnormal gait. Observe sitting, standing and transferring. Observe while standing. Look for C sign, means cupping the painful anterolateral hip. Modified Tran-Dillenburg test, that is single leg stance phase. Observe for limp or altered gait, waddling gait, antalgic gait, pelvic rotation wink. Moreover, observe for inability to bear weight, such as hip stress, fracture, hip septic arthritis, avascular necrosis of the hip, or any femoral lesions. And finally, observe for inability to climb onto examination table, that is decreased hip joint flexibility iliopsoas muscle or quadriceps muscle weakness. With this, it's over, guys. Thank you all for your graceful support in part 1 and 2. Hope you find these videos helpful. If you are new to this part 3, please go and check out our part 1 and 2. The link is given in the description box. And also please hit that like button and drop a comment. And also please do subscribe. See you all next week with a new topic. Bye.